picture this scenario for a second. You are sitting in your kitchen.
Right.
The high chair is pulled up, and you are about to experience this highly anticipated developmental milestone.
Oh, giving a baby their very first bite of solid food.
Exactly. You are feeding an infant their first real meal. So maybe it's a small spoonful of mashed banana.
Or a carefully pureed strawberry.
Right. So they take the bite and they swallow. And then within a matter of seconds, literally seconds, one entire side of their face turns violently, vividly red.
It's terrifying.
It really is. We are talking about a striking, deep red flush spreading rapidly across their cheek and temple.
And as a parent or caregiver observing this, I mean, your immediate physiological response is just a massive spike in cortisol.
Oh, completely. Your mind immediately races to the most terrifying, yet seemingly logical conclusion.
Right. The severe food allergy.
Exactly. A potentially life-threatening allergy.
Yeah.
You're reaching for the phone. You're calculating the drive to the nearest pediatric emergency department.
Wondering if anaphylaxis is just moments away.
Right. But as we unpack the medical literature today, we're going to see how this terrifying visual presentation is, well, it's actually a massive diagnostic illusion.
A complete trick of the body.
Yeah. So welcome to the deep dive. Our mission today is to investigate this bizarre, highly localized, and quite frankly, widely misunderstood clinical phenomenon.
Known as infantile Frey syndrome.
Yes. We're going to explore why it happens, how it manages to trick incredibly competent pediatricians.
Into ordering all these extensive and totally unnecessary immunological tests.
Exactly. And what it ultimately reveals about the astonishingly persistent and occasionally very clumsy ways the human body tries to heal its own nerves.
The clinical presentation you just described is really the perfect entry point into this topic.
Because it's just so visual.
Right. The visual evidence is undeniably alarming. When an infant has acute facial redness right after eating a new protein, the assumption of an allergy, an IgE-mediated allergic reaction, is just the default diagnostic pathway.
It's what everyone is trained to look for.
Exactly. But as we synthesize the data from our sources today, we need to completely shift our analytical framework.
We have to stop thinking about the immune system.
Yes. We are moving away from mast cells and histamine, and we are diving deep into the autonomic nervous system.
It's a wiring problem.
It is. We're dealing with a structural miswiring within the peripheral nerves rather than an immune system mounting an inappropriate defense.
And to really deconstruct this, we're analyzing a fantastic stack of sources today.
Some really incredible case studies.
Yeah, the foundational document is a comprehensive 48-patient retrospective French national study.
Published in the Journal of Pediatrics.
Right. And, 48 patients might seem like a small cohort for a global study.
But for a condition this incredibly rare in infants, it represents a monumental effort.
Oh, the cross-specialty coordination alone to find those 48 kids is staggering.
And we are supplementing that big data with a striking clinical image case report from the New England Journal of Medicine.
Which is going to give us the vital visual context for exactly where this flushing happens on the face.
Plus a really detailed pediatric otolaryngology case report.
That one is my favorite. It perfectly illustrates the real-world friction between a hyper-observant parent and standard medical algorithms.
The value of combining that large demographic data set from the French study with these granular individual case reports is huge.
It lets us see the macro and the micro.
Exactly. We can track the pathology from a physical, mechanical event that frequently occurs during childbirth.
An event that stays completely clinically silent for half a year.
Right. Only to dramatically manifest the very second an infant tastes a specific food.
Okay, let's unpack this and establish the clinical baseline.
Let's do it.
The medical literature defines infantile Frey syndrome through a very specific cluster of symptoms. First, transient facial flushing.
Second, localized warmth or hyperthermia in that specific area.
And third, though it's rare in babies, localized sweating or hyperhidrosis.
But crucially, this does not happen randomly all over the face.
Right, the redness is strictly confined to one very specific territory. The cutaneous territory innervated by the auriculotemporal nerve.
And the timing is the ultimate clue here.
It's so fast. The infant starts chewing, or they get a taste of something that makes them salivate, and within seconds to maybe a minute, boom.
Unilateral vasodilation, just one side of the face flushes.
And it lasts for as long as they're eating, and then it fades away rapidly.
Usually resolving entirely within minutes to an hour after the meal.
That precise localization and that rapid temporal onset, that speed, that should immediately signal to a doctor that they are looking at a nerve reflex.
A neurological reflex arc, exactly, not a systemic immune cascade.
We're specifically talking about the temple area, the cheek area, and that little spot right in front of the ear, the pretracheal region.
The history of how the medical community actually figured out this specific anatomy is pretty revealing, honestly.
Yeah, because people had been noticing this for a long time.
Oh, centuries. Localized facial sweating and flushing while chewing was documented in the mid-1700s.
By Kostremski in 1740, right?
Yep, and Duphoenix in 1757. They both published accounts of it.
But for nearly 200 years, nobody knew why it was happening. It was just this weird physiological quirk.
An etiologic mystery.
I found that remarkable reading through the sources. Generations of doctors just writing down, patient eats, one side of their face turns red and sweats, and having no idea what the mechanism was.
Until 1923.
Right. The puzzle was finally solved by Lucia Frey.
A brilliant Polish neurologist.
And if you think about neurology in the 1920s, she didn't have MRI machines or advanced electrotesting.
It required incredible clinical deduction.
She mapped the lesion and traced this incredibly complex interplay of nerve fibers, and she definitively linked the sweating and flushing directly to the auriculotemporal nerve.
She provided the definitive anatomical explanation, which is exactly why this syndrome bears her name.
But our sources make a very critical distinction here that we really need to emphasize for you.
Yes, the adult version versus the pediatric version.
Right. Frey syndrome in adults has a completely different clinical context than the infantile form we were talking about today.
In adults, it is actually quite common.
If you look at maxillofacial surgery, it's a heavily documented complication of parotid gland surgery.
The parotid glands being the largest salivary glands right in front of the ears.
So when a surgeon removes a tumor from the parotid gland, they are navigating one of the most nerve-dense areas of the human body.
The facial nerve and the auriculotemporal nerve are right there in the fascia.
And the rates of adults getting Frey syndrome after this surgery are shockingly high.
The sources show a range from 6% all the way up to 96%.
96%. That means structural damage to these nerve pathways during that specific surgery is almost unavoidable.
Adult surgeons expect it. They warn their patients, hey, a few months after this heals, you might sweat and flush on one side of your face when you eat.
It's a known variable. But when we look at the babies,
the surgical context vanishes completely.
These infants have perfect, unscarred faces. No scalpels, no parotid surgery.
The redness just appears completely spontaneously out of thin air.
Which is exactly why primary care pediatricians get so caught off guard. They aren't looking for a post-surgical complication in a baby who has never had surgery.
And that brings us to the core diagnostic trap the French study highlights.
The timing.
Yes. The median age for the onset of these symptoms in the 48 infants was exactly 5 to 6 months of age.
And why is that timing so critical?
Because that is the exact developmental window when parents start food diversification.
Introducing solid foods.
Right. For the first 6 months, an infant drinks breast milk or formula. It's liquid, it's homogeneous.
It doesn't require a lot of saliva.
Exactly, just a low-level continuous salivary response. But at month 6, you give them a novel, complex food.
Like our highly acidic strawberry puree.
That new taste demands an intense, immediate surge of saliva to break it down.
So the parent feeds them the strawberry, the brain screams for saliva, and seconds later,
the unilateral flush erupts.
The correlation is just too visually perfect. The parent sees a new food and an immediate skin reaction.
The logical deduction is an allergy.
And the psychological impact on the parent in that moment dictates everything that happens next. They rush to the doctor, they report a severe food reaction.
And the pediatrician, operating in this highly defensive protocol-driven system where missing anaphylaxis is catastrophic.
They immediately initiate the allergy protocol.
Setting up the central thesis of our deep dive.
We are looking at a harmless mechanical nerve routing error, perfectly masquerading as a systemic, dangerous immune response.
To understand how this masquerade actually works on a cellular level, we have to talk about the anatomy of the face.
Right. Let's look at the trigeminal nerve, cranial nerve 5.
It is the main highway for sensory input from the face.
And it splits into 3 branches, with the lowest being the mandibular branch.
Also known as V3.
And branching off from that is the auriculotemporal nerve,
which runs up the side of the face right in front of the ear, supplying sensation to the temple and the jaw joint.
But this is where it gets interesting, because it isn't just a simple sensory wire.
No, it's a mixed nerve.
It carries 2 completely different sets of autonomic instructions in the exact same bundle.
You have the parasympathetic fibers and the sympathetic fiber.
The parasympathetic fibers are the secretomotor nerves. Their job is to tell the parotid gland to make saliva.
So you taste that strawberry. The brain sends a signal down the parasympathetic lane saying, make saliva now.
But right alongside those fibers, wrapped in the exact same sheath, are the sympathetic fibers.
And they don't care about saliva at all.
Right, they bypass the gland entirely and go straight to the skin. Their job is to control sweat glands.
The pseudomotor function.
And to control the tiny blood vessels in the skin.
The vasomotor function, causing them to dilate or constrict to manage heat.
So you have saliva commands and skin fleshing commands traveling down the exact same highway.
And the core mechanism behind infantile Frey syndrome is a disruption of that shared highway.
But not a clean cut, like a surgeon's scalpel.
No, the hypothesis here is local trauma in the form of a crush injury. An axonotmesis.
The structural scaffolding of the nerve gets squeezed and crushed, but the nerve isn't fully severed.
When a nerve gets crushed like that, the fibers past the injury site actually degenerate.
But the outer tubes, the connective tissue framework, stays mostly intact.
Which means the nerve can try to regenerate. The broken ends start growing back, trying to find their original targets.
But because it's a mixed nerve, with saliva wires and skin wires right next to each other in this crushed, disorganized space,
the routing gets chaotic.
This is the phenomenon of aberrant axonal sprouting.
The regenerating nerve fibers literally lose their way.
The parasympathetic fibers, the ones that are supposed to go to the salivary gland, accidentally sprout into the empty tubes that belong to the sympathetic skin fibers.
They cross paths. The wires get crossed.
So fast forward 6 months. The nerve has fully matured with this glitch.
The baby eats the strawberry.
The brain fires an electrical signal down the saliva pathway.
But when that signal hits the site of the old crush injury,
it gets derailed. It travels down the hijacked skin pathway instead, directly to the blood vessels in the cheek.
The biochemical command for make saliva arrives at the blood vessels.
And the blood vessels misinterpret that signal as a command to dilate immediately.
The precapillary sphincters relax, blood rushes in, and boom, sudden, localized red flush.
The baby's nervous system is literally trying to make their cheek skin salivate.
Exactly. But since skin doesn't have salivary glands, the physiological result is just a profound vascular flush.
It is an exquisitely specific error in neural routing. It's just brilliant and flawed at the same time.
It really is, but there is a huge difference here between adults and babies that we need to point out.
The sweating discrepancy.
Right. In adults who get this after surgery, the main symptom is actually sweating. Gustatory sweating.
Because the regenerating fibers hijack both the blood vessel wires and the sweat gland wires.
Yet in the French study, out of 48 infants, only 10% had any observable sweating.
90% just flushed red. No sweat.
The sources give two really solid scientific reasons for why babies flush but don't sweat.
The first one is just about maturity, right?
Yes, the developmental ontogeny of the eccrine glands. Basically, baby sweat glands are immature.
They aren't fully responsive yet. So even if the crossed wires reach the sweat glands, the glands themselves can't produce enough sweat for us to see it.
That's the first theory. The structural immaturity makes the miswiring invisible.
But the second reason has to do with the type of injury itself.
A surgeon's scalpel makes a clean, sharp cut. That creates a massive gap that the growing nerves have to jump across.
Which leads to wildly chaotic regeneration. The fibers just grab onto whatever they can find, blood vessels and sweat glands alike.
But a crush injury is a blunt compressive force. It damages the nerve, but it leaves the internal architecture a bit more intact.
So the regeneration is less chaotic. The crossed wires might only drift slightly into the blood vessel lane while leaving the sweat gland lane alone.
Which naturally brings us to the biggest question.
Right. If these babies haven't had surgery, what on earth is crushing the side of their face hard enough to cause nerve degeneration?
This is where the methodology of the French study is just indispensable.
Jabbering 48 cases is hard enough, but they didn't just group them all together.
They stratified the cohort. They split them into two distinct groups based on how the redness appeared.
Unilateral cases, where the flush is only on one side of the face.
And bilateral cases, where the flush happens symmetrically on both sides of the head.
And that split was the key to solving the mystery.
Let's look at the unilateral group first. 35 cases.
When the researchers looked at the birth records of those 35 infants, the correlation was undeniable.
Unilateral Frey syndrome is overwhelmingly associated with instrumented vaginal deliveries.
The odds ratio was 29.
Which is astronomical in epidemiological research.
Right. Usually an odds ratio of 2 or 3 is a strong link. 29 basically proves it.
It means an infant with unilateral Freys has 29 times the odds of having been delivered with obstetrical instruments.
We're talking about forceps or spatulas.
Right. When labor is prolonged, a doctor might use metal forceps to assist in delivering the fetal head.
And where do those metal blades clamp down?
Exactly along the sides of the baby's skull, spanning the cheekbone and the exact temporal area we've been talking about.
Directly over the auriculotemporal nerve.
The mechanical pressure during a contraction is immense. The metal blade compresses the soft tissue of the face right against the bone,
Crushing the nerve.
and the clinical data backs this up perfectly. 68% of the unilateral babies had visible bruising ecchymosis at birth.
Exactly where the forceps pressed against their cheek. The physical footprint of the crush injury.
So the timeline suddenly makes perfect sense.
Hour 0. The baby is born, the nerve gets crushed by the forceps.
The bruise heals over a few weeks, everyone forgets about it.
But deep inside the face, the nerve is spending the next 6 months slowly regenerating and crossing its wires.
The glitch is installed, but it stays silent because the baby is only drinking milk.
Until month 6, the strawberry puree arrives.
The massive salivary command fires.
And the 6-month-old birth trauma finally reveals itself as a bright red flush.
It is a delayed functional manifestation of a resolved structural injury.
That explains the 35 unilateral cases perfectly. But what about the 13 bilateral cases?
The babies who flush symmetrically on both temples.
Right. Because bilateral forceps deliveries clamping perfectly on both nerves is incredibly rare.
The data showed no statistical association between bilateral Freys and forceps deliveries. These cases are largely idiopathic.
They just happen spontaneously. So if it's not a crush injury from the outside, it has to be coming from the inside.
The sources suggest that bilateral cases might be congenital, a familial autonomic dysfunction.
Basically a neurodevelopmental error that happens in the womb. The nerve pathways just grow with the wires already crossed.
The evidence for this is actually really compelling. There's a case in the literature of 2 sisters who both developed bilateral Freys.
Both born via normal vaginal deliveries, no forceps.
The fact that identical bilateral miswiring happens spontaneously in siblings strongly points to a shared genetic encoding.
Not lightning striking twice with mechanical trauma.
Exactly. A localized genetic dysautonomia.
So whether the wires get crossed by forceps or by genetics, the biggest question parents have is this permanent?
And the longitudinal data from the French cohort gives us some really profound reassurance here.
The outcomes are great.
They really are. And they differ slightly between the 2 groups.
For the unilateral babies, the forceps cases, 69% of them saw their symptoms naturally fade over time.
The redness got lighter, it happened less often, or took a much sourer food to trigger it.
Mostly resolving by the time they were 2 or 3 years old.
But the bilateral cohort was even more striking. 58% of those kids had complete spontaneous resolution.
The symptoms entirely vanished within their first year of life.
Which is a huge difference from the adult post-surgery patients.
Right. Adults almost never recover from this spontaneously. The glitch is permanent.
But the infant nervous system has an extraordinary amount of neuroplasticity.
The baby's brain is constantly rewiring itself based on what it's experiencing.
So the brain essentially realizes, hey, sending a saliva command to the cheek skin is functionally useless.
And it actively prunes those aberrant synapses. It corrects its own wiring error.
It's a brilliant display of self-correction.
So we had the big picture data now.
Yeah.
But I want to look at how this actually plays out in a doctor's office because the diagnostic friction is intense.
The pediatric otolaryngology case report is a perfect example of this.
The 9-month-old boy.
Yes. Let's look at his history. He was delivered via forceps. He had bruising on his left cheek at birth.
Yak.
He also had torticollis, a tight neck muscle often caused by a difficult delivery.
So all the historical markers for a traumatic crush injury are there.
And at 6 months old, right on schedule, the parents notice his left cheek turning red when he eats.
But the triggers in this case are what make it so illuminating.
He flushed when eating bananas, yes.
But he also flushed when he vigorously chewed on his plastic teething toys.
Which is the ultimate diagnostic pivot point.
If a baby's face turns red from chewing on a piece of inert plastic, you can immediately rule out a food allergy.
There are 0 allergenic proteins in a plastic toy.
The trigger is purely mechanical. The physical act of chewing tells the brain saliva is needed.
The reflex arc fires, the crossed wires route it to the skin, and the cheek turns red.
And the mother in this case report was brilliant. She noticed this logical inconsistency.
She realized an allergy to plastic was impossible.
So she went online, searched the exact symptoms: forceps delivery, one-sided flush, chewing triggers.
And she correctly diagnosed her own son with infantile Frey syndrome before she even saw the specialist.
Her critical thinking saved that kid from so much unnecessary medical intervention. She literally handed the doctor the correct neurotraumatic hypothesis.
We see a similar story in the New England Journal of Medicine case.
The 2-year-old boy.
Right. 18-month history of right-sided flushing when eating.
Forceps delivery, right-sided bruising at birth.
The photos in that report are amazing. They did a provocation test in the office.
They took a picture of him looking completely normal. Then they gave him fresh strawberries. And moments later, his right cheek and temple are profoundly, sharply red.
But before anyone figured out it was a nerve reflex, that poor kid had been put through the ringer.
Extensive allergy testing. They tested him for a huge panel of common allergens.
All of which came back negative.
Which highlights the real danger of misdiagnosis here. The French study really hammered this home.
When doctors mistake a nerve glitch for a severe immune threat, the treatments they prescribe can be incredibly harmful.
21% of the infants in that study were put on strict elimination diets.
Taking essential proteins, fats, and nutrients out of a growing baby's diet.
Just a massive source of anxiety for the parents, trying to feed a baby while terrified that the next bite might cause anaphylaxis.
And all to treat a harmless nerve misfire that requires zero dietary changes.
Plus, the testing itself. Over half of these kids had invasive skin prick tests or blood draws for IgE antibody panels.
Looking for an allergy in the blood when the problem is a millimeter of crossed nerve in the cheek.
And the craziest one baby was actually prescribed mandibular manipulation.
Physical therapy and chiropractic adjustments on the jaw joint.
Because the doctors just had no idea what was causing the flushing. It shows how desperate they get when they don't have the right framework.
Which is why the differential diagnostic checklist in the literature is so vital for you to know.
Table C in the sources. It gives a clear 4-part framework to tell Frey's syndrome apart from a real food allergy.
Step 1 is the speed of the reaction.
Frey's is electrical. It happens in seconds to a few minutes. And when the chewing stops, the redness fades fast.
An allergy takes longer to build up, and it lasts much longer, usually needing antihistamines to go away.
Step 2 is location. Frey's is highly localized. It's a sharp, demarcated flush on one cheek or temple.
An allergy is diffuse. It spreads everywhere. You'll see hives and mucosal swelling around the lips and eyes.
Frey's syndrome never causes swelling. Step 3 is sensation.
Frey's doesn't hurt or itch. The baby is totally unbothered by it.
But histamine from an allergy causes intense itching and discomfort. The baby might be wheezing or throwing up.
And step 4 is the trigger.
Frey's is triggered by things that make you salivate. Acidic foods, sour fruits, dense purees, or chewing on a toy.
Allergies are triggered by specific proteins like cow's milk, eggs, or peanuts.
If a baby's cheek turns red from a strawberry, but they can eat eggs and peanut butter perfectly fine, it's not an immune issue.
If you apply those 4 steps, a doctor can confidently diagnose infantile Frey's without drawing a single drop of blood.
And if they want to prove it in the office, they just do what the NEJM doctors did, the provocation test.
Give them the trigger food and watch it happen.
Interestingly, our sources noted that doctors skipped the classic diagnostic test used for adults.
The minor test?
Right, the starch and iodine test.
In adults, they paint the cheek with iodine, sprinkle starch on it, and give them a lemon wedge.
When the adult sweats, the moisture mixes with the iodine and starch and turns dark blue, proving where the nerve is firing. But because 90% of babies with Frey's don't sweat,
painting their face with iodine would just give you a false negative. You have to rely on the clinical presentation.
And once you confirm the diagnosis, the treatment is wonderfully simple.
Reassurance.
That's it. For adults with severe sweating, they might do Botox injections to paralyze the nerve.
But for babies, absolutely zero medical intervention is needed.
It's completely benign, and the brain will likely fix the wiring on its own as they grow.
The only treatment is empowering the parents with knowledge so they can feed their child without fear.
So we've tracked this from a terrifying red flush in a high chair, through the neurology of the 1920s, down into the mechanics of forceps deliveries.
And finally to this brilliant, slightly confused rewiring of the nervous system.
We've seen how a structural crush injury leads to an autonomic routing error, where a saliva command gets hijacked and dilates the blood vessels instead.
And for anyone evaluating a weird symptom like this, it just highlights how critical it is to look past the obvious assumption, like an allergy, and consider the actual mechanics of the body.
Exactly. But before we sign off, I want to leave you with a fascinating observation buried deep in the discussion section of the French study.
Oh, the anarchic colonization.
Yes. The researchers noticed that in some of these babies, the redness didn't just stay inside the territory of the auriculotemporal nerve.
It spilled over. It expanded into the wider cheek area.
And they hypothesized that this implies anarchic colonization, meaning when the crushed nerve fibers start growing back, they don't just cross lanes within their own sheath.
They exhibit this aggressive plasticity. They actually grow outwards, crossing tissue boundaries to invade and colonize entirely different nerve networks in the face.
Which is just biologically wild. If a localized crush injury at birth can trigger a nerve to aggressively colonize new territory and permanently alter the face's blood flow.
What else is happening inside us?
Exactly. Think about how many minor compressive injuries, localized inflammations, and structural traumas we all survive over a lifetime.
Countless.
If this kind of anarchic colonization is just how human nerves repair themselves, is it possible that every time we get injured, our internal autonomic wiring is being silently, irreversibly redrawn?
It suggests our nervous system isn't a static map.
It's a continuously evolving patchwork of chaotic, adaptable reroutings. Every time you heal, you are quite literally wired differently than you were before.
That is a staggering thought.
It really is. Thank you for joining us on this deep dive. Keep questioning the mechanics of the world around you, and we will see you next time.